Greetings, everybody, and thank you for attending session 2 of the Lurie Children's Sleep Medicine Team's virtual roundtable. We are here today with Dr. Stephen Sheldon. My name is Chad Worley, and I am the physician liaison for Lurie Children's, and I cover the north and northwest suburbs as well as the north side of the city. But not about me today, it's about Dr. Sheldon and the rest of the sleep medicine team. So what I'm going to go ahead and without further ado, he's got a lot to talk about. So Dr. Sheldon, why don't you go ahead and take it away?
Thank you, Chad.
You're welcome.
Usually at the beginning, I will present you with the objectives, and I will kind of visually present you with the objectives if I can. And I'll start with a story. My son, who is now a lawyer, which I regret, but he's still my son. When he was younger, he came home one day and he came up to me and he said, "Dad, what's this?" And I looked at him and I said, "David, I have absolutely no idea what it is." And he looked at me and he smiled and he said, "Well, Dad, I don't know what it is either, but here it comes again." And that's the direction that we will follow today, because we're going to be talking about expiratory sleep-related respiratory events and apneustic-like breathing and apneustic-like events during sleep in children and what their significance might be. Now, typically, respiratory events are defined as follows. And these are the definitions of the American Academy of Sleep Medicine that were originally published and revised in 2017. An obstructive sleep apnea is an event that occurs during sleep that it is greater than or equal to 2 obstructed respiratory efforts where there is no airflow from the nose or mouth. It is defined as a 90% fall in the flow signal for greater than 90% of the event, and there's continued respiratory effort. It's measured from the beginning of the last normal breath to the beginning of the pre-baseline effort, and this is what an obstructive apnea looks like. You can see, can you see the cursor here? I hope.
Yes.
Okay. You can see that the chest and abdominal channels show continued respiratory effort, actually with a little different pattern from baseline, which would be here. It's a little bit of an increase in rate and then a crescendo effort. But looking at airflow, which is a thermal channel, pressure channel, and end-tidal CO2 channel, there's really no flow. So this is an obstructive apnea. At the outset, I'd like to mention that the end-tidal CO2 waveform, when it is displayed on these epochs that we will be discussing, there's about a 3 to 5 second sampling delay. So this respiratory exhalation is responsible here. It comes from this. So there's a little delay in the signals, because we do side stream end-tidal CO2, which requires air being aspirated from the airstream at the nose and mouth to be aspirated into the tube, and the tube is about 5 feet away from the patient, and the sampling chamber is 5 feet away from the patient. So it takes time to travel down the tube and into the sampling chamber. So this delay, if you have questions, I can show it to you again. But this is what an obstructive apnea looks like. This is also an obstructive apnea here, where there is a flat end-tidal CO2 waveform, a flat pressure signal, and there's continued respiratory effort. There's about 180-degree phase shift in the chest and abdomen when compared to normal respiratory pattern. And that is an obstructive apnea. A mixed apnea holds a similar definition, where there are greater than or equal to 2 obstructive respiratory efforts without flow, and there's a 90% fall in the flow signal for greater than or equal to 90% of the event. However, there's absent inspiratory effort at the beginning of the event and resumption of effort at the end. And this definition has changed because the absence of effort can either be at the beginning of the event or at the end of the event. And this is what a mixed apnea looks like. And this will be further discussed when we talk about these expiratory events and apneustic-like respiratory efforts and respiratory breathing in the child. And here again is the sampling delay. But what is interesting about this event, which meets all of the criteria for a mixed apnea, is that there is absence of respiratory effort at the beginning of the event. Then there's resumption of effort near the end of the event for at least 2 respiratory efforts. And this is more, this is about 4 or 5 respiratory efforts before beginning airflow again. However, if you take a look closely at the end-tidal CO2 waveform, there is exhalation with gradually increasing EtCO2, gradually increasing carbon dioxide that's exhaled, that reaches at the end-tidal CO2 point a maximum of 55 millimeters of mercury. So this really is not a central event, which a mixed apnea is typically described. It is an expiratory portion of the event where there is respiratory flow in only one direction. And because the way the chest and abdomen signals are being recorded by DC amplification, when there is no inspiratory and expiratory effort that's alternating, the signal is filtered back to the baseline as flat. So if there's effort out only, then you will see a flat signal on chest and abdomen, but you will see a flat signal on the airflow and PTAF, which is the pressure channel. But you can see that there's continued gradual rise of the carbon dioxide to a maximum of 55 millimeters of mercury before there is no flow again with the obstruction. And that is a mixed apnea. And you can see again here with the pause at the end of the event, with efforts at the beginning of the event. A central apnea is the absence of effort throughout the entire respiratory pause, plus one of the following is met. The event lasts greater than or equal to 20 seconds, so they are long events. And this is important when we talk about expiratory hypopneas and apneustic-like respiratory breaths. And it lasts for at least 2 respiratory efforts of pre-pause respiratory effort associated with either an arousal, an awakening, or greater than or equal to 3% desaturation. And this is what a central apnea looks like. There is no effort in the abdomen, no effort in the chest. There is no pressure flow, and the end-tidal CO2 waveform falls to 0 throughout the event. And again, this is the sampling delay here and here. Okay, and that is a central event. With this event, there is oxygen desaturation to a nadir of 67%. From a baseline of 100%, but there really are no EKG changes at all throughout the duration of this event. And this is a 2-minute polysomnographic segment. A hypopnea is a partial obstruction where it follows the same pathophysiologic process of obstructive sleep apneas, but there still is airflow that is noted because the hypopnea must meet all these criteria according to the AASM, greater than or equal to 30% fall in the pressure or an alternative signal. And this is important because all of the footnotes in the manual of scoring chooses alternate signals if one signal is inappropriate. And therefore, we are looking at three signals in our polysomnogram. We're looking at a thermal signal, we're looking at a pressure signal, and we're looking at the end-tidal CO2 waveform, because often we will lose one or the other signal, and you can use alternate signals to identify hypopneas and apneas. There are two partially occluded respiratory efforts, so it has to last for at least two respiratory efforts, a fall in pressure for at least 90% of the event, and arousal, awakening, or greater than or equal to 3% desaturation. So this is partial obstruction because there's only 30% fall in pressure, plus arousal, awakening, or greater than equal to 3% desaturation. And this is what a hypopnea looks like. Again, this is the sampling delay. This is a 30-second polysomnographic epoch. And you can see there's continued respiratory effort that lasts greater than 2 respiratory efforts in baseline. There's a little increase in the respiratory rate during this period of time. There is still some airflow in the thermal channel. The pressure channel falls to 0. And there's a change in the end-tidal CO2 waveform so that no longer do you have a nice alveolar plateau, but you lose the alveolar plateau. It becomes more peaked. So you're looking at more dead space air in these respiratory flow channels, in the end-tidal CO2 flow channel than you would see normally. And that is an obstructive hypopnea. Now, there are other events that we look at polysomnographically. One is a RERA, which is a respiratory effort-related arousal. And this is part of the continuum of increased upper airway resistance. And a respiratory effort-related arousal is scored when the nasal pressure falls, but it's less than 50% from the baseline, or less than 30% from the baseline. There's flattening of nasal pressure waveform. There's snoring, noisy breathing, elevated carbon dioxide as measured by TCM or end-tidal CO2, or there's notable increased work of breathing, and it must last for 2 respiratory cycles, or the duration of 2 respiratory cycles as determined from the baseline. And it has to be associated with arousal. And these are respiratory effort-related arousals. You can see that the pressure channel doesn't fall very much, but they're periodic. They're associated with arousal, with a limb movement and electrocortical arousal. And this is a 5-minute polysomnographic segment, and another arousal with a limb movement, and another arousal with a limb movement. And these are respiratory effort-related arousals. Finally, as part of the continuum of obstructive sleep disordered breathing, it is obstructive hypoventilation. Obstructive hypoventilation is scored when greater than 25% of the total sleep time is spent with a carbon dioxide as measured by end-tidal CO2 or TCP-CO2 greater than 50 millimeters of mercury. This is usually associated with snoring, pausing, snorting, and gasping, but it doesn't necessarily have to be associated with any significant or apparent obstructions. It frequently is, but it doesn't have to be. And as long as the carbon dioxide is greater than 50 millimeters of mercury for more than 25% of the total sleep time, it is considered obstructive hypoventilation. Now, what about these expiratory events, these things that we really have seen all the time, and everybody kind of shrugs their shoulders when we see these expiratory apneas or hypopneas? They actually were first described by David Southall in 1985 in Lancet, the September issue. And he described prolonged expiratory apneas in neonates that were associated with significant desaturations and cyanosis. These events were also suggested by Dr. Onal and Lopata back in 1982, when they were isolated events rather than persistent events, where there were prolonged inhalations, a sigh, followed by a prolonged exhalation or respiratory pause, which may be considered either a post-sigh pause or something else. Dr. Onal liked to call these events post-inspiratory apneusis. Not a lot of people liked the suggestion of that term, but it is a good definition or a good explanation of what we actually are looking at. The question is whether this is normal or abnormal. We see it all the time in children. We have seen, we started looking at these events a long time ago when an 8-year-old child came into our clinic at a different institution, and he had his apnea monitor in his backpack, and he was going to school with his apnea monitor in his backpack. And when he came to the sleep center, there was a 3-inch notebook of pneumograms and home monitoring studies that were done that were abnormal, and every one of them was checked abnormal, continue monitoring, abnormal, continue monitoring. We had the child into the laboratory and did a polysomnogram and found that he had these prolonged expiratory pauses where there were deep breaths and prolonged pauses that lasted 25 seconds or longer, but were really not associated with any cardiac changes or significant oxygen desaturation. These events were quite interesting, and the child was breathing out during these respiratory pauses. We were clearly convinced that the child was breathing out because there was expiratory noise and an expiratory stridor. And it sounded like this. And that expiratory noise lasted throughout the entire event. In order to make that noise, there had to be expiratory flow. And so we started looking more closely at these events, because monitoring an 8-year-old child who really has no significant sleep disordered breathing was not appropriate. In 2012, we published a study that we looked at a number of children coming through our sleep center. And we looked at expiratory events and whether or not they were pathological or whether or not they were normal physiological events that occurred during sleep in children. And we found that there were really 2 kinds of events, or 3 kinds of events, that we identified. In order to understand them, I would like to just break down for a minute the end-tidal CO2 waveform. If you look at the pressure channel, you see inspiration and exhalation running similar to a sine wave curve. The end-tidal CO2 waveform, though, is quite different, and it is characterized by several segments. Between point A and point B is the beginning of exhalation. At point A is the post-inspiratory portion, and that's why Dr. Onal classified these as post-inspiratory apneusis, because it begins here. And this first part between A and B is the beginning of exhalation, and we're measuring dead space air that's really coming from the nose, the nasopharynx, and some from the hypopharynx. Between B and C is the continuation of exhalation, and between B and C is also dead space air, but from larger airways, the trachea, main stem bronchi, and perhaps secondary bronchioles. Between C and E is called the alveolar plateau. The alveolar plateau is where gas exchange occurs. And when exhalation finishes at point E, that is the point of end tidal CO2. So the carbon dioxide is measured at the end of a tidal breath, and this is inspiration between E and D, and it doesn't end until point A again on the next curve. So by understanding the characteristics of the end tidal CO2 waveform, we can look at these expiratory events in greater detail. This again is a mixed apnea or an expiratory hypopnea, but since there are a couple of respiratory efforts which may have flow, they probably are not, but you can see that it begins with an augmented breath. There's a greater than 50% increase in inspiratory effort and exhalation begins. During the first part of the event, there is persistence of a prolonged alveolar plateau until that exhalation slows down. You begin to see some cardioballistic artifact in the end tidal CO2 waveform. And it begins with a little electrocortical arousal. This is a sigh. And then there's prolonged exhalation after this sigh. What we see also happening with these events is that during the arousal and sigh, there is an increase in the heart rate. As you can see by the narrowing of the RR interval, the RR interval becomes shorter and shorter, suggesting increasing instantaneous heart rate. And then really during the beginning of the event, there is a cardiac deceleration, which is likely due to two factors. The first factor is a vagal response. So where there's a tachydysrhythmia, there's a vagal response to decrease the heart rate. But also there's a mechanical response, because if there is forced exhalation, so the patient is exhaling with increasing expiratory effort, with creating it in the abdomen and in the chest, then there's a mechanical decrease in cardiac venous return, which will also decrease the RR interval to decrease cardiac output because of decreased central venous return, with gradual rise of the heart rate back to baseline prior to another arousal here. And that is an expiratory hypopnea. This again is another event that is identical, beginning with a brief electrocortical arousal and increased chin muscle tone with a sigh breath and a respiratory pause, which may look central because there's no effort, apparent effort, except the effort is out. And you can see a continuous rise in the end tidal CO2 waveform until the maximum end tidal CO2 is 50 millimeters of mercury at the end of this particular event. So there has to be movement of air outward. Again, and more demonstrable here in this event, you can see the tachybradydysrhythmia at the beginning of the event, with gradual rise of the heart rate to baseline during the second half of the event. So these are not central apneas. These are expiratory hypopneas, and we originally called them apneas because of the absence of airflow, but because there's airflow out, then it is more likely or better termed a hypopnea. This actually is the same way a Valsalva maneuver occurs. If you monitor the heart rate during a Valsalva maneuver, where there is indeed an apnea, there's a deep breath, there is an occlusion of the upper airway, and respiratory effort out. The heart rate there originally has a tachydysrhythmia, then a bradydysrhythmia with gradual return to baseline. Although with the Valsalva maneuver, this probably would be flat because the upper airway is typically totally closed. These events can occur in isolation, and we have found that they are normal respiratory events and are intermittent during the sleep time, and are not pathologic unless there are certain characteristics. One, if they are surrounded by obstructive apneas, the airway can obstruct on exhalation as well as inspiration and as well as both. So it could be a manifestation of obstructive sleep apnea. Normal post-sigh respiratory pauses or post-sigh expiratory apneas or hypopneas are likely normal physiologic events because we see them almost all the time in youngsters. Now, the problem is that they can last pretty long. And this event, if you're not monitoring the end-tidal CO2 waveform, may be construed as a central apnea because there can be oxygen desaturation, there can be arousal at the end of the event, and it doesn't look like there's flow either in the airflow channel effort, there's no effort, and there's no airflow. We only know that there's airflow by the end-tidal CO2. If this isn't being monitored, then it can be misscored as a central apnea and then artificially elevate the central apnea index to a point where sometimes it may be abnormal. Yet these events are really normal physiologic events. There are other events that follow post-sigh, and they are post-sigh respiratory pauses where you really don't see the changes in the heart rate and you don't see elevation of the end-tidal CO2 to a great extent, except for the beginning of the event. And the post-sigh respiratory pauses, again, are normal physiologic events that should not be included in calculation of the central apnea index or in calculation of the apnea plus hypopnea index or the respiratory disturbance index. They're normal events, unless they happen often. This is a patient that has obstructive sleep apnea, and you can see that they are very, very periodic. There's snoring, and the snoring tends to wane as the obstruction becomes more significant. There's a gradual slowing of the heart rate at the end of the event and an arousal. And these are obstructive events. This is an obstructive hypopnea. We don't have the pressure here, but it's also following a post-sigh pause. But and it may have been scored as a mixed apnea because of this particular portion of the event. And you can see, but when we added the end-tidal CO2, you can see how there's a gradual rise again in the end-tidal CO2 waveform prior to the resumption of respiratory efforts. Now, this is a different pattern. This is a pattern of apneustic-like breathing. There is an increased respiratory inspiration, and the inspiration lasts for a longer period of time, and there's prolonged exhalation, and there's also corresponding cardiac decelerations, likely due to vagal response in these particular events. Some mechanical, but probably mostly vagal. The difference here, which makes this not normal, is the periodicity of these events. They occur in series. They're not separated by periods of normal respiration. They're occurring during non-REM sleep. This is apneustic-like breathing, where there are prolonged inhalations and prolonged exhalations, and they are usually indicative of a posterior fossa abnormality. We have seen these this respiratory pattern in youngsters who have had undiagnosed Chiari-1 malformations, and this was resolved once there was posterior fossa decompression. It can also be seen with posterior fossa tumors or other posterior fossa abnormalities, and this is a pattern of apneustic-like breathing and it's not normal because they are in series and they are periodic. Again, if you don't have an end-tidal CO2 waveform, these look like central apneas, but once you add the end-tidal CO2 waveform, you can see the prolonged alveolar plateau and the expiratory phase of these events. So, what are expiratory apneas and hypopneas, and what do they mean? What are the events? Why are they important? And should they be scored? We have seen what these events are. They're post-sigh respiratory pauses that are pathologic in only certain circumstances. They are important because they can be very prolonged, and we have seen them last from 20 to 35, 40 seconds in length, and can be scored as prolonged central apneas in a normal child, in an otherwise normal child, that may result in excessive expense for the patient and family, because with a diagnosis of central sleep disordered breathing, they have to have imaging and further diagnostic workups when these events are likely totally normal. Should they be scored? I do believe they should be scored, but I do not believe they should be included in the calculation of the apnea plus hypopnea index, the central apnea index, or the respiratory disturbance index. So they should be scored so that we get a better understanding of what they are and how frequent they are and how normal they are, or maybe they mean something else until we start looking at them and seeing them and isolating them from other respiratory events. We might never know. So the question is, here they come again. We see them over and over and over again, and too often we see them scored as central apneas. And should we or should we not score them separately? I will end with some quotes. One is, if you can't explain it simply, you don't understand the process well enough. Anyone who has never made a mistake never tried anything new. And when all people think alike, no one thinks very much. So we need to start thinking about these things that we see all the time and really either ignore or don't ignore inappropriately. And that was not from me, that was from Albert Einstein, who also said a lot of other things which I love, but I won't bore you with them. Thank you very much, and I'm open for questions or discussion.
Yeah, that was great. Thank you so much. Lot of great slides there that I'm sure explained a lot to folks.
You want me to stop sharing?
Yeah, if you don't mind, that'd be great. And then I will go ahead and share my screen so I could share with the crowd. But while I'm doing that, a question came in here, and I encourage everybody in the room here to go ahead and ask some questions as we had earlier today. One question that came in is there a typical age when apnea starts to present?
Typical age that apnea starts to present. It can present at any age.
Okay.
It can present in preemies. You can see both obstructive and central respiratory pauses in premature infants. And as Dr. Southall described, in some children who have neurologic problems in the neonatal period, they can present with prolonged expiratory apneas. But I do think that any age, they can start at any age as long as the child is born.
Okay. If you have any other questions out there, feel free to unmute yourself and fire away. All right. That's okay. We
Problem not, that's the problem with not having video on everybody. You can't see who's.
well, that and lunchtime, right? So maybe the
Lunch.
mouths are full right now too. So I'd like to thank everybody for joining us today, and especially thank you, Dr. Sheldon, for taking us through that today.
Well, thank you for inviting me.
You're welcome. And for everyone who is watching right now and who will be viewing this later on a recording, on your screen here, you'll see that there is a direct number into the Sleep Medicine Center, as well as an email address. And don't forget, there's always Lurie MD for everybody to call in. And I'd like to remind you that tomorrow we have a couple great sessions as we continue our Sleep Center roundtable series. And tomorrow morning at 7:30 is our session 3. And that's Dr. Keaton, who will be talking about sleep disturbances with neurologic disorders. And then at 12:30, Dr. Dang will be talking about parasomnia. So very good day tomorrow. And Thursday, we're excited to bring in Dr. Trossman to talk about our sleep studies. She'll be joined by Regina Palamo, who's a sleep center manager. And then a first for us here for the Lurie Children's Physician Services team, as we do these roundtables, we are having a special multidisciplinary discussion between the sleep medicine team and a couple of ENT doctors. So Dr. Trossman will be representing the sleep medicine team, and Dr. Velika and Dr. Gattersoy will be representing ENT. So we're excited about that. But if nobody has any other questions, I'm going to go ahead and sign off and just thank you everybody for joining us today. And I would say have a great day, and we'll see you tomorrow.
Thank you.
Thank you.